Combine a transarterial transvenous approach in the management of dural fistula. I would like very quick set, but we don't have time. So I think not only I start of treated of with combined arteriovenous approach. In Hungarian start this other doctor, and you see this picture. It's absolutely don't understandable of what happened. You can see harm 3 coil. One coil in right side of maxillary artery, one in vein jugular, and in left side it's close of external carotid artery. I do, this is angiography, a terrible situation, close of external carotid artery, patient have chemose, diplopia, oculomotorius paresis. So what possible do in this situation? So not only I treat with combined arteriovenous approach in Hungary. So this is left side. Possible C of cavernous branches in fistula, and left internal carotid artery, left external carotid artery. So it is very, very difficult, close of external carotid artery, impossible catheterization. And the only one possibility is transvenous approach. I see one small feeder, and with my technique, I push at head close of parent vessel and wait, and after embolic material go in distal part of dural fistula, and I close in maybe right side of AVM transarterially, and after it is anterior projection, and it is embolic material after embolization, and I start transvenous approach. This is angular and artery and superior ophthalmic artery vein and superior ophthalmic vein, catheterization of and superselective angiography, and I close with embolic material this dural fistula. This is next patient. Interesting for dural fistula, very typical of occlusion of sinus. We see many times this occlusion of sinus rectus and sinus transversus and sagittal sinus. But interesting why you see it is dural fistula is convexital but close of transversus sinus in 2 sides. For me, it's not very understandable why, but in situation in big intracranial cerebral AVM, this not happen. It's happen only in situation with dural fistula. And I would like show this interesting of dural fistula. This same patient, and you can see dural branch from posterior cerebral artery, and this is vein, this is Falcine sinus. And this is very interesting for me in situation with vein of Galen malformation. So after embolization, and we know very important, in situation, would you like close of dural fistula, of target of embolization is this dural branch, not of subcutaneous branches. And I close this dural fistula. The next patient, it's very interesting, very small dural fistula. Our patient was a coma, arrived in my clinic. And you can see thrombose of sinus rectus, and fistula is very small. And stagnation in basilar vein and in internal cerebral vein. So this is anterior projection, this is superselective catheterization, and I close, this is fistula. But problem is stay why, but sinus rectus did not work. And the next step, this is angioplastic of sinus rectus. And interesting, after this procedure, the next day, patient wake up without problem. So the next cases, this is dural fistula, and not very big, but look what happened with venous system. This is small fistula. This is vertebrobasilar system, and you can see of posterior cerebral artery have dural branch. And same situation, typically occlusion of sinus transversus in sigmoid sinus. And after occlusion of dural fistula, you can see a result and normalize it of venous system after treatment. This is interesting cases. You can see vertebrobasilar system. This is not posterior meningeal branch. This is dural branch of not only of posterior cerebral artery. You can see it's dural fistula from pharyngeal ascendens artery. And one branch of dural starts from superior cerebral artery and left side posterior cerebral artery. So we don't understand all about dural fistula. This transvenous approach, before and after, I don't close of pharyngeal branch, and fistula is done. It's control angiography with only one procedure. Look at this vein of Galen malformation, is same situation, and we know two classifications, is Yassar-Gil and Pierre-Lajunias, yes? But look what happens, this vein of Galen malformation, but you can see many dural branch. This is the next patient with tetra paresis. This young boy, but why tetraparese? Same situation, close of sinus, is vein of Galen malformation, and you can see this is vein same with dural spinal vein, and this produce of tetraparese. It's external carotid artery, you can see dural branch. Transvenous and transarterial approach is embolic material in after embolization and result. And I close the dural branch. Usually, typically, for dural fistula, this is Farcine sinus. This is vein of Galen malformation, but this is not sinus rectus. This is Farcine sinus, it's primitive Farcine sinus. And this is not intracerebral AVM, it is dural fistula. 3D reconstruction, and after treatment with very, very small quantity of embolic material. Same situation, vein of Galen malformation, and this is Farcine sinus. It's not sinus rectus. Catheterization, and after operation, this child is absolutely. The next, same is vein of Galen malformation with hypertrophy of myocardium. Terrible AVM, and look, this is not sinus rectus. And after operation, 2 weeks. So I think of vein of Galen understanding need reconsideration. But we don't understand all about this pathology. And I sure of vein of Galen malformation. It is deep dural fistula. Thank you.
So, for the very first time, I disagree with you. You know, I'm not responsible of the embryological development, but this is the very well-known, which has been described by Charles Rebaud, French neuroradiologist doing pediatric screening in Marseille. This is what we call the vein of the prosencephalon. This is a precursor of the vein of Galen. So you cannot say that it's a dural disease. It's a venous, deep venous system disease, which is draining in the precursor of the vein of Galen and which is usually shrinking and disappearing at the time the straight sinus is occurring. When you have this malformation, you have no straight sinus because it has not developed yet. So it's not another type of dural malformation. It's a true direct fistula between brain arteries and vein of the arteries. This is what we call an duroarachnoidal type of malformation, but it's a normal drainage in a normal vein, which is a precursor of the straight sinus and the vein of Galen. No, this is the embryology. If you look at Miss Paget's work, you know, it has not been described by the guy who discovered this. It has been explained by Charles Rebaud, and then Pierre Lajonias, you know, capture what Charles Rebaud said, and he continued to develop this, and I agree. The point that I disagree with, you know, the regular strategy for the treatment of vein of Galen and your position, you have to occlude the venous system. And attacking the vein of Galen from the venous side is not a shame. It is exactly what you have to do. Occlude the vein. You can do it from the vein or from the artery, but you have to occlude the vein. If the baby is 2 days old, you take an artery, you decrease the flow, you pass the cardiac failure, but then you don't wait. After 2-3 weeks, when the baby is fine, 1 month maximum, you go and you occlude everything. I have been looking at the 25 years follow-up of the vein of Galen done in Bicêtre Hospital, and believe me or not, but the paper is going to be published. All the patients that had a vein of Galen, typical one, either mural or choroidal, a typical vein of Galen, we were not completely occluded and left like that because they were fine, clinically speaking, and the cardiac output was controlled. All of them developed bilateral brain AVM, bilateral thalamic brain AVM. So there is no reason to stop occluding the venous system. When the child has passed the cardiac failure, go occlude everything and avoid having this evolution. Now you don't know what to do. It's a bilateral thalamic brain AVM.